Welcome. My name's Jennifer Roeder. I'm a communications consultant for APFED, and I'll be moderating today's webinar about living with EGIDs. Joining us today is Dr. Narendra Vadlamudi. Dr. Vadlamudi is a pediatric gastroenterologist at Children's Hospital of Richmond at VCU. He serves as medical director for pediatric endoscopy and leads the multidisciplinary eosinophilic esophagitis clinic. His clinical interests include eosinophilic esophagitis, gastroesophageal reflux, and inflammatory bowel disease. And he is actively involved in quality improvement initiatives, medical student education, and resident mentorship. Welcome.
Thank you, Jen, for having me, and thank you, APFED, for giving me this opportunity to talk about living with the EGIDs. Let me share my slides. So today we're going to talk about living with EGIDs. EGIDs stand for eosinophilic gastrointestinal diseases. I have no disclosures to discuss today. So although the topic is about living with EGIDs, what I always believe in is without knowing about the disease, what it can do to the patients and families if left untreated, and what are the signs and symptoms of progressive disease, and not knowing what treatment options, how they work, and what other associated comorbidities and the treatment options and how they work and things like that. Without knowing that information, it's hard to plan day to day and how to come up with strategies in managing conditions like EGIDs. So we will discuss about a few things today. First thing is we're going to talk about define EGIDs. The EGIDs include eosinophilic esophagitis, eosinophilic gastritis, duodenitis, enteritis, that includes the jejunum and ileum, which are parts of small intestine, and eosinophilic colitis, which is involvement of the colon. We will look into how common it is, how it happens, and any link to genetics and things like that. And we'll also talk about the symptoms, any allergy manifestations, and also we will discuss about endoscopic and histological features of EOE and eosinophilic gastroenteritis and colitis. We will also briefly review the treatment options and then go to our main topic of day-to-day management. As we briefly discussed, EGIDs stand for involvement of the whole GI system through eosinophilic infiltration. Eosinophil is, by now, most of you guys are aware of what an eosinophil is, but to bring up about how eosinophil works in the body, that may help some of those people who just started their journey with the eosinophilic gastrointestinal conditions. So eosinophil is a white cell. They are about 5% of all the white cells. They are produced in the bone marrow, and they work by fighting off some of the infections, especially parasitic infections. And also they mediate these allergic reactions as well. So they play a major role in allergies. So in GI tract, it is not uncommon to see the eosinophils in the GI system, especially in the stomach or the small intestine and the colon. When we look at this, when we look at the stomach and take tissue samples and look at microscopy, when we see the eosinophils, it is not uncommon to see them there. But if you see eosinophils in the esophagus, which is the food pipe, it is always considered as abnormal if you see eosinophils in the esophagus. So if you see cells there, we always need to focus on what conditions are bringing those eosinophils in the esophagus. We can see up to 10 cells when we look at microscopy within the segment of the biopsy specimen. You can see up to 10 cells in the stomach. You can see up to 20 cells in the small intestine, and then up to 15 to 50 cells in the colon. So how common is it? In children, it is about eosinophilic esophagitis is by far the most common of all the EGIDs. In children, it can be up to 25 to 30 per 100,000 children in the States. In adults, 35 to 45 per 100,000. And annually, there are about 6.5 new cases per 100,000 patient years. Eosinophilic esophagitis is interestingly more common in males than females, whereas the EGIDs, including the gastritis, which is involvement of the stomach, small intestine, and colon, appears to be more common in females compared to males. The prevalence of EGIDs in children is not very clear. It is anywhere between 2 to 8%, 2 to 8 per 100,000, but some studies said it can be much higher than that because this condition is often underdiagnosed. In adults, a few papers suggested up to 40 per 100,000 in the United States. But a lot of research need to happen, need to be done to better understand this condition. So, because of the topic of living with EGIDs, I thought it's always important to understand about how these generally kids can present with, so that some of the patients and families can relate their own symptoms or their own children's presenting symptoms with the EOE or EGIDs. So let's start with case one. A 7-month-old with feeding or food refusal behaviors and weight loss presented to us. At the time when she presented to us, the patient was on breastfeeds. The exam was unremarkable, other than there was a little bit of eczema on the chest. This patient already had skin testing, which was all negative, and most importantly, the weight dropped from almost 40th to 2nd centile. And we tried changing formulas and tried increasing calories, but none of them helped. And so because there is no progression, we scheduled this patient for an endoscopy to see what's going on. To your left, this is the pictures of the endoscopy. To your left, this is a normal appearing esophagus where you can see normal surface, which is very smooth, pinkish, and you can see little lines, which are the blood vessels underneath this superficial layer of the food pipe. To the right, the pictures of this patient, you can see the lining appears a bit more paler and thick, and you can see some white dots in the lower esophagus. Clearly, it looks a bit different than how it should appear in a patient who don't have any esophageal disease. So the second case came in, this is a 40-year-old, came in with abdominal pain, had reflux symptoms for a long time, mostly after eating. Patient also experienced intermittent diarrhea, especially after eating. And the most recent symptom, which prompted them to come to the hospital or come to see PCP first and then to GI, was choking during meals. And also looking through the growth chart, this patient had not gained weight for almost 2 years. So when I did the endoscopy showed pale looking esophagus, and then there were few lines that we saw in the esophagus. Normally you should not see these lines. So when you see this, something is happening in the esophagus. And when we looked into the stomach showed some kind of overgrowth of the lining inside, which are called polyps. We saw them in the lower part of the stomach. The third patient is a 12-year-old with no significant prior history, presented to the ER with food impaction. This kid was eating a piece of steak, and then the gut stuck, so they could not swallow any saliva and feeling a lot of pressure in the chest. So went to the ER, and they called me and went in, and I did the endoscopy. And of course, this picture is after I took the food bolus out of the esophagus. You can see the esophagus again looked a bit more thicker, the lining appears thicker, and then you can see some lines and some remnants of the food in the mid part of the esophagus. And then last case, so 80-year-old came in with history of regurgitation, meaning food coming back up from the stomach into the throat. And patient also complained of chest pain, difficulty in swallowing, and progressive weight loss. There was no significant history other than asthma, and the rest of the examination findings were negative except for some weight loss. We did some blood tests. Everything was normal except elevation of one of the allergy antibody. And the patient has had allergy testing done outside, which showed allergy to dairy, egg, and soy. And of course, because of this ongoing symptoms of weight loss, we did an endoscopy. And this esophagus looks much worse compared to the other ones that you just saw. It looks very red, very fragile, with contact bleeding, and the whole layer is sloughing off when we went into to look at the esophagus. So clearly, this esophagus is much more severely inflamed compared to the others. So why I presented all these different cases? Because we see different varieties of symptoms. Interestingly, they all could be coming from the same underlying condition. As we saw, first case, a 7-month-old with food refusal behaviors, eczema, and failure to thrive. The second one came in with bellyache, reflux symptoms, diarrhea, and choking. Third one came with food impaction, and fourth one came in with persistent reflux symptoms for a long period of time. And they all had different endoscopy pictures. And one common thing is all of those children's biopsies confirmed the diagnosis of eosinophilic esophagitis. The kid who had diarrhea as well also had eosinophilic gastritis and eosinophilic colitis. So this is a typical presentation. We do see patients with UE in children coming in with different manifestations. The same thing with the gastritis and colitis as well. So we spend most of the time on the eosinophilic esophagitis because this is by far the most common of all the EGIDs. So what happens in eosinophilic esophagitis is it's a chronic condition triggered by some antigens, mostly the food, and that antigen-related inflammation happens in the food pipe, and in the food pipe, the eosinophils come in, and the eosinophils secrete more chemicals, leading to swelling. And the swelling eventually affect the function of the esophagus. So essentially, the problem is the esophagus doesn't move the way it should be. And the function of the esophagus is once you swallow the food, and the esophagus helps to push the food down into the stomach. So if the esophagus doesn't move the way it should be, kids feel that food getting stuck. Kids feel that they can't swallow the food and things like that. So this is what happens when the patients ingest the allergen, or when they inhale some, the airborne allergens. Few patients can have triggers through airborne allergens, but majority of them are through food allergens. So when they ingest it, when it goes and touches the esophagus, it triggers the inflammatory cascade where it sends the contact sends some chemicals. They go to the bone marrow. Bone marrow activates the white cells, and then white cells in turn secrete more chemicals. And these chemicals push the eosinophils into the esophagus. And the eosinophils themselves secrete more chemicals, which attract even more eosinophils. And the eosinophil secreted chemicals can cause swelling in the esophagus, as we briefly talked about, leading to dysfunction. So what exactly happens underneath when we cut the esophagus transversely and then look through the wall of the esophagus? There are three layers. Primarily, the innermost layer is the epithelium. When we pass the scope, and this is the lining where what we see from inside, and then this is called submucosa, which is a layer behind underneath the epithelium, and then the one underneath the submucosa is the muscle layer. And what happens is whenever the food allergen come and touch the lining in some patients, it can leak through what we call it as an epithelial barrier. It goes through the barrier into the submucosal area and activate some of the white cells there. And then these white cells secrete chemicals, and the chemicals attract the eosinophil. And the eosinophil cause all the tissue damage that we see when we do the scope. And the eosinophil also activates some of the chemicals which stimulate what a cell called fibroblast. The fibroblast is the cell that deposits the scar tissue. So the eosinophil trigger the deposition of the scar tissue. This happens with continued exposure of this allergen. So the scar tissue deposition happens in the middle layer, and the chemical that is produced by eosinophil sometimes act on the muscle as well, leading to inactivity or decreased activity of the muscle, leading to dysmotility, what we call it as. So the eosinophil can cause damage to the surface, lead to deposition of scar tissue in the middle, and then make the muscle not move the way it should be. So, how the disease progresses over a period of time. So this is the lumen of the normal appearing or normal esophagus. When the inflammation starts, it usually stays in the innermost lining and without impacting the lumen. And as the inflammation progresses, the esophagus starts thickening, and that will take up some of the space in the middle. And over a period of time, the esophagus can get so thick, the patients can present with a narrowed esophagus, or we call it as esophageal stricture, and leading to food impactions and things like that. So, is it a one-time disease, or is it something that patients carry the rest of their lives? So there are population-based studies that they looked into whether this is a progressive kind or this is like an intermittent but not so progressive kind. And on the x-axis, if you look at the x-axis, there's a patient years, and on the y-axis, this is the probability of developing the stricture. And as the age progresses, you see more and more patients are presenting with stricture in the esophagus. So this is a progressive disease. So that is one of the reasons why, especially in pediatrics, we try to focus on controlling the inflammation as quickly as possible, so that the patients don't experience the symptoms of stricture. So what are the symptoms of EGIDs? For eosinophilic esophagitis, the most common symptoms are food refusal behaviors, choking. Patients can have reflux or vomiting. And most common symptom with progressive disease in pediatrics, at least, is difficulty in swallowing and food impactions. But as the disease involves the rest of the parts of the GI system, if it involves the stomach, patients can present with abdominal pain or nausea, feeling full after eating small bites. And as the disease enters into the small intestine, or patients presenting with the small intestinal disease, they can have diarrhea, sometimes blood in the stool, bloating, cramps. The bleeding and diarrhea mostly seen in patients with the colitis, but rarely can be seen with inflammation in the small intestine as well. And if there is a longer segment of the small intestine is involved, it can impact digestion and absorption of the nutrients, leading to weight loss. Constipation has been reported, and sometimes the inflammation can go through all the layers of the intestine, and patients sometimes can present with some fluid collection in the belly cavity. So I'm a pediatrician. I work with children, only with children. So we always want to look into the type of symptoms that they're presenting with, and based on the age and the type of symptoms, we discuss about how quickly we should go with endoscopy. So again, the x-axis, the patient age, and then the y-axis, the different types of symptoms that they can present with. The younger the children, the common symptoms that they present with are food refusal behaviors, or texture issues and things like that. And as they grow older and older, that means that as the disease progresses, the esophagus becomes thick and stiff. So they present with more symptoms of difficulty in swallowing and food impaction. We talked about different symptoms, but the symptoms are not always obvious. They may not have any symptom, but there are a few signs that if the patients are aware or parents are aware, they may be able to pick up early enough before the disease starts progressing. So parents may sometimes see change in the kids' eating patterns, meaning that they may start refusing to eat textured foods, or they may start drinking water every time they are eating solids. Kids may not tell what is normal, what is not normal, unfortunately. So these signs can help identify the disease process early enough. Sometimes they go through a lot of clinics before coming to the GI clinic, especially feeding therapists, because it can be mistakenly diagnosed as food avoidance behaviors. And sometimes comorbidities can lead to visits with other specialists like pulmonologists or dermatologists secondary to asthma and eczema and things like that before presenting to the GI. And sometimes financial burden is a problem that often diagnosed or under-addressed. And one of the studies that was published in 2020 showed that depression has been noted in up to 40% of the children, and of those, 28% of the patients require medical therapy for anxiety and depression. And in teenage years, panic attacks appear to be very common, especially they're worried more about the food impactions and then choking episodes. So what causes it? Many factors have been reported to cause the problem. One is environmental factors like environmental allergies or antibiotic use or infections and things like that. And immunological factors such as atopic conditions like asthma and eczema may make the patient prone to have eosinophilic gastrointestinal conditions. And genetic factors play a bigger role. For example, in general population, the risk is about 5.5 per 100,000, but in siblings, the risk can be 2.4 per 100 children. So the risk is higher in siblings, and of course in twins, if they are dizygotic or monozygotic twins, the risk is even higher. So this tells us that there's a genetic predisposition for this disease. And there's a quick slide about the risk of EOE in children with allergic rhinitis, AR stands for, or the children with asthma or atopic dermatitis or food allergies. Children with these conditions are at increased risk to have EGIDs. And the orange line is a normal patients with EOE without history of any atopy, and the patients with EOE with history of atopy, and there's a blue line. So you can see the blue line indicates that patients with either allergic rhinitis or asthma or any other atopic conditions, they have a higher chance of developing EOE compared to general population. How do you diagnose it? Unfortunately, there are no specific, no pathognomonic symptoms. There are no specific symptoms that would tell us whether the patient has EGIDs. So you have to have a high index of suspicion, and look at the patient's history may help, or family history may help, or if the patient have other comorbidities can help in diagnosing, or at least make us think about potential possibility. No specific lab tests or x-rays that we could do, and no obvious endoscopy findings as well. No specific skin testing that can help us identify this condition. But the diagnosis is made by the biopsies. But unfortunately, one biopsy showed that we sometimes may miss the diagnosis, especially in EOE, we may miss the diagnosis by 50%. So we need to do more biopsies to have more accurate diagnosis. So biopsies are the key for us to be able to diagnose the condition. Can X-rays help? X-rays help sometimes. So one of these kids presented to me a while ago with the difficulty in swallowing. But the swallowing was severe enough that the patient was having to switch her diet to purely liquid diet for a long period of time. So the patient was doing this purely liquid-based diet for a long time. We wanted to know how severe the disease is. So we did a contrast X-ray. This is the normal diameter of the esophagus, and you can see the strictured segment, which showed a significant narrowing in the mid part of the esophagus. So this patient clearly had a reason for difficulty in swallowing, and had to switch to liquids because only thing that could go through that narrow segment was a liquid. So endoscopy is the key. So as I've shown you before, this is a normal endoscopy, normal appearing esophagus, and these are different types or different appearances of eosinophilic esophagitis. They can appear like, esophagus can appear like concentric circles or circles with some white dots, or maybe vertical lines you may see, vertical lines with the white dots. So patients can have a combination of any of these things that may indicate eosinophilic esophagitis. But in pediatrics especially, a normal-looking esophagus cannot rule out eosinophilic esophagitis, unfortunately. So even though esophagus appears normal, if you have a high index of suspicion, it is important that we take the biopsies. So how does eosinophilic gastritis appear? It may appear like a red esophagus, or patients may have some ulcers. And this picture that I've shown you before, this particular patient had what we call as polypoid lesions in the stomach. So it's overgrowth of the innermost lining. And in the small intestine, you can see some redness, ulcers, and sometimes you lose the innermost lining, which is called brush border, which helps to digest the enzyme. So because of the inflammation, patients may lose the lining, leading to diarrhea and malabsorption. And sometimes in the colon, you can see the ulcers and redness throughout the colon, depending on the severity of the condition. If you look under microscopy, so biopsies are the key. Biopsies are the most important part of the diagnostic requirements. When we look under microscopy, the esophagus, this is how the normal esophagus appear like. This is the top layer, which is the epithelium, and this is the middle layer, which is lamina propria or submucosa, and then there's a muscle layer. And there's a closer view of the surface layer. And the one on the right is a patient with eosinophilic esophagitis, where you can see all these purple and red cells. These red cells are the eosinophils. You can see a clear difference between the middle picture and then the one on your right. So the one on the right, the patient has eosinophilic esophagitis. what we look for under microscopy is a number of red cells, and then we count per quarter of the visual field. So how would you diagnose them based on the cells that you're seeing? The eosinophilic esophagitis is diagnosed if we count those cells greater than 15 from the esophageal biopsies, greater than 20 to 30 from the biopsies from the stomach, greater than 20 from the biopsies from the small intestine, and greater than 25 to 50 from the biopsies of the colon. So the count is important. Count can help us clarifying what is going on underneath and what could be the likely diagnostic possibility for this condition. So once you have the diagnosis, what we do, there are the majority of the patients, it is triggered by the food. So dietary restriction appears to be very helpful, and it helps to resolve the condition in majority of the patients. But dietary therapy is not for all, so the alternate option is medications. In the dietary therapy, there are few options. One is a single food elimination diet, or 2, 4, or 6 food elimination diet, and targeted food elimination using the skin testing, and then elemental diet are the 4 options. Elemental diet being you take away all the foods and give the kid or the adult, if the adult is on the elemental diet, only a formula, which is a hypoallergic formula where there are no allergens, and just purely keep them on this diet and see whether the patient would respond to it. We used to do the targeted testing directed elimination before, but it became much more difficult for the families because there's no significant difference between following the targeted the testing directed elimination versus empiric elimination. So it's now out of favor, and in our practice we stopped doing this almost 8-9 years ago, or maybe longer than that, I believe. So because there's no significant benefit of following this compared to empiric elimination, so we don't use this in routine practice right now. So this is one of the studies that were published in 2014. They showed that in children, if the kids are on elemental diet, almost 96% of the patients responded to the treatment within 6 weeks. 6-food elimination diet helped in 74% of the patients. Directed approach is 72%, closer to the 6-food elimination diet. And in this particular study, if they took out milk only as the only food elimination, it helped in achieving remission or good control of the disease in about 65% of the patients. This number varied in different papers, but usually about 50 to 60%. In adults, whereas a single food helped in about 30% of the patients, 2 foods up to 65, and 3 or more foods greater than 80% of the patients appeared to be beneficial. So what are the 6 foods? Dairy, soy, egg, nuts, fish, and shellfish. So this is the top 6 foods, and avoiding all these 6 foods achieves about 70% response. And again, in this study, they showed a significant response with 6-food elimination. So again, on the x-axis, we're looking at the time, the before and at 6 weeks. And then on the y-axis, we are seeing the number of eosinophils. Some patients had more than 200 eosinophils. And at the initiation, these patients had many eosinophils in the esophageal biopsies. And at 6 weeks after introducing the 6-food elimination, and following that 6 weeks later with the repeat endoscopy, majority of the patients showed a significant drop in the eosinophil count, indicating a good response. So 6-food elimination does help. But the problem here is what do we do after you take out the 6-food elimination, and then what happens? So once you take the 6-food elimination and you do, well, you work on 6-food elimination diet, and 6 weeks later you do endoscopy and you achieve remission, that the disease is under control, then what do? We do introduce 1 food at a time, and unfortunately, as we talked about, there's no other test that we can do to see whether the disease has gotten better or not. The only way you can tell is by doing an endoscopy, look at the esophagus, and take tissue samples. So with every reintroduction, we introduce 1 food at a time, and they're followed by repeat scope. And in terms of which food you start with first, it changes from patient to patient. The majority of the times, we let the patients decide, so that the success is much higher if patients and parents are involved in the decision-making process. We introduce one food followed by an endoscopy, and we end up in repeating many scopes to be able to identify which food's causing the problem. And then once you achieve the remission, you discuss with the patients and families to continue removing those trigger foods and continue eating the foods that seem to be safe. So I'll give you an example of one of my patients. 80-year-old came in with difficulty in swallowing and had a lot of reflux symptoms associated with it. And the patient had one episode of food impaction. When we did the endoscopy, and I saw a lot of inflammation, especially in the middle to lower part of the esophagus, you can see a lot of swelling and some ulcerations, and biopsies confirmed eosinophilic esophagitis throughout the esophagus. And when we took away 4 foods, dairy, soy, egg, and wheat, and I usually wait for 2 to 3 months before I repeat the endoscopy. And when I repeated the endoscopy, the esophagus was completely normal appearing, meaning that the patient had a reaction to one or all 4 foods at that point. And then we began introducing one food at a time. When we introduced wheat, inflammation came back. So clearly wheat is one of the trigger foods. And then we discussed eliminating wheat and introduced egg. Everything is clean. That means that the egg is a safe food. And then soy introduced, and there was a relapse. So soy is not a safe food, and dairy appeared to be a safe food. So in this patient, we were able to identify wheat and soy as the triggered foods. So the patient now began eliminating wheat and soy and able to eat dairy and egg. And this patient remained symptom-free and in remission for a very long time until I transitioned to adults. So dietary therapy helps, but the problem is compliance. Cost is a problem. Patient had to go through a lot of scopes. But the benefit is that you know what foods that are causing the problem, and you can avoid medications. So you can stay on these food restrictions for a long time. But the problem is that not all patients can follow this food elimination diet, or not all patients respond to this. So for those patients who don't respond to 6 food elimination, there's a different pathway that we take, but it becomes much more difficult for the patients to stick to food elimination after 6 food elimination, because you end up in taking out many foods and then just one at a time. It requires a lot of coordination, a lot of involvement, and a lot of scope. So at this point, we'll have a close discussion with the family and decide what would be the next best step for that particular patient and family. So the alternate option is the medications. The different medications, medication options. The acid blockers is an option. Topical steroids is an option. Oral steroids and biologics are different options. The acid medications is one of the commonly used medications. The studies have shown that the acid blockers can help control the inflammation. But one of the studies published in 2018 has shown that the histological remission, meaning that remission confirmed by looking the tissue samples under microscopy, the remission was achieved in now 66% of the patients. But the problem is we'll have to give twice daily dosing for at least 8 to 12 weeks to get to this remission state. And this study looked into the response rates after 1 year. At 1 year time frame after starting the medication, the response rate had dropped a little bit down to 55%. So the problem with this is that we are achieving about 50% after 1 year of being on this high dose anti-acid blockers, but we don't have any studies long term on what happens after 1 year of age, which becomes a part of discussion before we start this medication, the discussion with the families and see whether it's really the right choice. The next option is steroids. There are 2 types of steroids. One is Pulmicort, which is budesonide, and the other one is an inhaler or Flovent, fluticasone. The way you give is the inhaler is an inhaler you put in the mouth and have the patient hold the breath and puff it and have the patient to swallow it. The idea is you want this medicine to go into the esophagus and then stay on the surface of the esophagus so that it can help kill those allergy cells. So the advantage is that it is killing the allergy cells as they come, so the patient can actually eat and drink all the foods that they want to, and even the foods trigger the inflammation, and the inflammation brings the eosinophils. This medicine helps to kill those allergy cells, so that there won't be much damage or happening, or heal the inflammation that's already happened. With this pulmicort, the budesonide is a liquid. We ask the parents to make it as a paste and then swallow it, and then not to eat or drink for 30 minutes with either of these medicines, so that we're giving enough time for the medicine to stay on the surface and help heal the inflammation. Now we have a commercially available medication approved by FDA. We don't have to mix it at home. It comes with pre-mixed, which makes the life a bit more easier. Does it work? I'll give you an example of this particular patient. Who came to us with difficulty in swallowing and having issues with food getting stuck. So we started this kid on reflux medication for almost 8 to 12 weeks. And when we repeated the scope showed persistently active inflammation throughout the esophagus with eosinophils greater than 50. They stopped counting after 50 because there was so many of eosinophils. So clearly this patient did not respond to reflux medicines. We started the kid on budesonide 1 milligram twice daily for 8 weeks and stopped reflux medicine because it was not working. Symptoms have significantly improved, and the endoscopy looked completely clean. There were no eosinophils in the esophagus. So the budesonide do work in patients. The only issue is that the side effects of the medications, including thrush, and the thrush sometimes can itself give symptoms to the patient, which can confuse the picture. There are some concern about whether it can get absorbed into the system and then lead to issues with weight gain or block some of the hormone production, a gland called adrenal gland. But more studies are needed to see whether this really has any significant clinical implications. So the advantage of the medicines is that they can eat whatever they want. Cost is less. It can be beneficial in a greater portion of the patients. But the problem is having to use this for a long term. Side effects of the medications. Compliance is a problem. And most importantly, not all patients respond to the medications. In several studies, it's shown that up to 50% of the patients may not respond to steroids. So steroid, unfortunately, is not for everybody. The next option, especially in kids who have severe disease, the next option is biologics, which are monoclonal antibodies, and the antibodies designed to fight off against these inflammatory markers or inflammatory proteins. So when you block those inflammatory proteins, the eosinophils will not be recruited in the esophagus, so the inflammation can be blocked. So there are a lot of biologics that were designed, and one of the most commonly studied one is called dupilumab, which works on these IL-4 and IL-13 proteins. Does these medications work, especially the dupilumab? Studies have shown that compared to placebo, these patients will have a significant drop in the eosinophil count once they are on this medication. So clearly this medicine do help if they take it. And there's another study published looking at the different doses of dupilumab and showed a significant improvement in the number of patients who are in remission compared to placebo. But the problem with the medicine is the Dupixent is that the side effects, the local reaction, the redness and rash is probably the most common side effect. But patients have shown to have increased risk for respiratory infections, herpes infection, and general allergic reaction. Fortunately, these are rare, but studies have shown that they do happen periodically. So this option also has its own complications or its own side effects to be aware of. So the reason why I mentioned about all these different treatments is why do we worry about all these treatments, and why do we focus on controlling this disease? So this patient presented to me when he was 13 years old with difficulty in swallowing. So when I stopped this kid, and you can see the esophagus is already significantly narrowed, and even the gentle push of the esophagus lead to a small tear in the esophagus, indicating that the lining is so fragile. And I ended up in dilating the esophagus, and then post-dilation, 6 weeks later, they're still narrowing, but it's better. But in the 6 weeks, I had to put the patient on elemental diet because when I scoped this patient, Dupixent was not approved at that time. So we put the kid on elemental diet, and there was some improvement in the inflammation, but the stricture was still there. So I ended up in dilating this kid a few times. And eventually we switched the kid to Dupixent when it got approved, and the patient is doing very well now. So we want to prevent the development of these strictures. So that's why we always want to sit down and talk to the parents and discuss about the treatment options right from get-go, so that we can avoid complications like these. So both diet and medications have their own benefits and risks, and we briefly discussed about those. The reason why I spend more time in the eosinophilic esophagitis is the treatment is more or less similar for eosinophilic gastritis or duodenitis or colitis. Again, the treatment is either diet modification or topical medications like steroids or biologics like dupilumab. Rarely surgical interventions are needed, especially if the patients develop severe stricture to a point where it cannot be medically managed. So it comes to the actual topic today. So I know it took a little bit of time, but the key is understanding about the disease, what it can do, and what treatment options is extremely important so that we can plan ahead moving forward. So we know how the disease progresses over a period of time. So what are the challenges with the EGIDs? The challenges is there's always a threat about food impaction. So the patients go through day to day worrying about the food impaction. That's a big challenge. And stress of strict food restrictions. Imagine a kid having to go through day to day without having to eat those foods, which are probably the most yummy foods everybody eats, but this particular patient cannot eat. So it's a very challenging thing for not only for the patient, for the family as well. And with restricting those foods, so nutrition deficiency is a big problem. Losing weight is a problem. And taking medications can be an issue, especially after you achieve remission. It's hard to convince the patients to take the medication daily, even though they are feeling well. So that can be an issue to be aware of. And of course, the stress and emotional impact, which we'll touch in a minute. Unpredictability and not knowing when the patient end up in having choking episode or food impactions, and unpredictability of accidental exposures to the foods that they should be avoiding. So that's a challenge. And ARFID is the avoidance restrictive food inhibitor disorder. So that means that patients, if you don't address these food refusal behaviors early enough in patients with the EOE, over a period of time, patients can develop restrictive behaviors where they don't like to eat, they don't want to eat, even though the EOE is under control. So that's a big challenge. That's why it's important to address this condition early enough, especially in younger children. And management is never unidirectional and not one size fit for all. Every patient is unique. Every patient's journey is different. Every patient have their own lifestyles that we need to work with, and we need to make sure that we discuss with the patient and then figure out what works best for the patient and the family. And then, of course, the challenges are with the medications and the side effects that we need to worry about, and of course, the challenges with the endoscopies and endoscopy-related complications. So, how do we manage day to day in patients who pick a dietary option as their treatment option? So, of course, we discuss with the patients about taking the foods away, but the problem is the patients and parents have concerns about, okay, I'm going to take dairy and soy out, but where am I going to buy them? And how am I going to look for these potential ingredients how am I going to cook those foods, and how am I going to prepare the meals for my child or my husband or wife and things like that. So those are concerning things. So what we discuss with the patients is having a meal plan, having a plan for the week can help sometimes. Or sometimes meeting with the dietitian, come up with nutrition goals and come up with a diet plan based on their food restrictions can help. And I always encourage the patients to talk to the physician and healthcare providers and see whether a step up or step down approach would be beneficial for you. Step up meaning that you start with one food or two foods to start with, and then gradually go up depending on the response. Whereas step down is you start with probably six foods and then or four foods and then go down. Step up can be more practical for a lot of families because it's relatively easier. It's never an easy thing, but relatively easier to start with one food restriction and then go up rather than step down. So having a plan can help. And for the patients who have history of food impactions, having a new lifestyle, meaning that training and coaching the patients and the children about chewing thoroughly before they swallow can help. Having a sip or two after every bite can help prevent any impactions, and then taking time to swallow can eat and swallow can also help avoid the risk of food impactions. It's very, very important to get self-trained or train the kids about label reading so that they know and they can pick if there are any ingredients that they're not supposed to have. And whenever there is accidental exposures, it's very, very important that there is an open communication between the patient and the parent, or school and the patient, or the parent, so that appropriate interventions can be taken soon enough before this can lead to a flare-up. And communication with the school, family, and friends is important. I'll briefly touch in a second. And connect with the communities, EGID communities, especially organizations like APFED can be extremely helpful. I was telling Jen a minute ago, I myself learned a lot by going through APFED. There's a patient community that you can learn from. Patient experience is much, much more helpful a lot of times than the providers themselves. So talking to other patients and families who went through conditions can be of enormous help. So having a community around you dealing with or going through the same thing as you can significantly help. Use the technology whenever you can. There are many apps that we can use to identify the trigger foods, identify the restaurants that are allergy safe, and having ideas about meal preparations and things like that. So these are different apps that are available. Most of them are free, so you can think about it. And most importantly, go through APFED. APFED has a list of meals that can be prepared using those food restriction patterns. The issue with medical therapy, though, is bigger issue is adherence. Almost 50% of the patients over a period of time shown to lose interest in taking the medication. So it's important that education is very important, and then build this as a habit of taking medication at regular intervals can be helpful. And also use technology such as MediSafe. These can send the reminders and alerts and things like that that can help in our busy lives so that we can take the medication. They can also give you a flow sheet about how many times you missed in the past month or past week, so that it can help you be more responsible. Stress and anxiety is, I want to spend a minute or two here. Stress and anxiety is often underdiagnosed and often we don't address in the clinical settings, and is an extremely important thing to be aware of. But the anxiety from the pediatric perspective for the children, worry about choking whenever they're eating, worry about restricting those foods, worry about not knowing what and when these things can happen. It can be very anxiety provoking. So it's important to take that into equation. For parents, all of those plus what to cook, where to cook, and how am I going to travel, and all of those can be very anxiety provoking. So having a multidisciplinary team on your site can be very helpful. Having a dietitian, having a psychologist can be very, very, very handy, especially when these anxieties flare up. And sometimes preparations like cook for a whole week and put in the refrigerator or put in the freezer and pick food of choice for that day, and preparing for the whole week can reduce the anxiety. And sometimes cooking for to prevent the accidental exposures, so we sometimes tell the family cook for the patient first and then cook for the rest of the family. It's easier to say it, but hard because now the mother or father have to cook twice the amount of time, so it may not be practical sometimes. So having a plan worked with the dietitian can be helpful. Talking to the patients and families can be, other patients who are going through this can be very helpful, especially parents of other kids who had similar journey, have been through similar journey, can be extremely helpful. Plan early when you're traveling, talking to the families, other families can help, and also calling the destination and see whether they have any allergy-friendly restaurants or whether they can have stores there where they can buy the stuff without these ingredients. Or if you're planning to stay there for a long period of time, or if you're going abroad or something like that, shipping the safe foods to the destination, and then use those supplies until you come back, and help reduce the anxiety related to travel planning. And there are a lot of apps that we can use, or you can use, that can help prepare yourself well. Wearing a medical bracelet can help, especially in emergency situations, when you are in difficulty in swallowing, when you had food impaction and you cannot speak sometimes because of the pain. Having a bracelet can help when whoever is providing the care can look at the bracelet, and then they can understand about what allergies that the particular patient has, so that they can help you avoid any accidental exposures. School, having a 504 plan can help so that they can avoid accidental exposures, and then they can allow extra time or carry during the lunchtime and carry water bottle all the time can help. Social situations, having a plan like eating before going to parties, or taking your own lunch or dinner, or the meal with you to the parties, or talking to the organizers and tell them about these allergies, so that they can hopefully make environment allergy friendly and things like that, can avoid some of the stress. And as I said, the support system is extremely important. And sometimes having a checklist about, if the patient had accidental exposures, having a checklist about what are the symptoms to monitor for that can indicate accidental exposures can be very helpful. For EOE, the IMPACT acronym can help, meaning that if the patient is drinking extra fluids, or cutting the foods into small pieces, or eating slow, or skipping textured foods, and chewing a lot to be able to swallow, and refusing to swallow, can help. So they keep the IMPACT acronym on hand, so that this will help understand about accidental exposures and potential flare-up of symptoms. So whenever there is a flare-up, two things can happen. One is either it is something that can be managed at home, or is it something severe enough that patients may have to go to the ER. So understand the symptoms that might require ER visits, such as the food impaction, such as tightness in the chest, such as can't eat or swallow. Those are the things hard to manage at home. So those are the things that will require either going to the ER or call 911. But if there's a flare-up but not severe enough, then it's important to look through for any accidental exposures, or look through whether there are any missed doses and things like that can help identify the problem early enough, so that this can be controlled before it lead to the severity of the symptoms. And if the patients don't respond, no matter what you're doing, then talk to your healthcare provider and see whether the management plan that you're on is the right path. Having a food impaction action plan can be very helpful. This I got from the UAS network, and there are many variations to this. Having this action plan can be very helpful. So where everything can be listed there, the person to be contacted, what are the allergies the patient has, and then medications taking, and this can help guide them what to do when the food impaction happens. So knowledge is very, very important. The reason why I spend most of my time in discussing about the condition is that without knowing that, it's hard to manage day to day. So knowing about the condition is very, very important. Reading labels is very, very important. And then understanding about having a community where you can communicate whenever there is an issue is very, very important. And most importantly, build your team. And I always encourage patients to take a second opinion. It's very, very important to have an open mind, so that they can take a second opinion, get the thoughts from other providers, and then see what works best for them. Thank you.
Thank you so much for your presentation. We really appreciate all the information that you shared with all of our followers. So we've got some great questions coming in. If you have not submitted a question yet, please go ahead and open up that Q&A tool, and then you can type in a question. We're going to go ahead and have a conversation for a few minutes. Alrighty, so we've got some questions coming in about elimination diets. And so one of the first questions that came in is, if someone goes through an elimination diet and then has foods reintroduced, is there a risk of developing an anaphylactic reaction to those foods?
Right. So the chances are very low. Can it happen? It's hard to know. That's why we always have an allergist with us whenever we do the discussion with this family. So because the allergist can look into the allergy perspective of it. Sometimes there's an entity called tolerance. I mean, patients may have had a mild allergy before, but patient was able to eat the food over a period of time and able to develop some tolerance. And when you remove the food and patient, there's a possibility the patient may lose the tolerance. And when we reintroduce the food, the patient may start exhibiting signs and symptoms of a flare up of or allergy to the particular food. This happens very rarely. It can happen. It happened with one of my patients a while ago. So that's why we always involve allergists into the picture. If the patient had other associated comorbidities such as eczema or asthma, things like that, they may have a slightly higher chance of having allergies in those particular patients. Sometimes the allergist would recommend doing some allergy testing before they go into the food elimination pathway. So can it happen? Yes, but to the point of anaphylaxis, generally very rare, unless you have a significant allergy to many foods. In that case, of course, patient will be tested before we put them through food elimination route.
A follow-up question from the same person. Is there any difference in the level of risk whether somebody does a 2-food elimination diet or completely removed foods?
So in terms of the risk we're talking about, or what was the risk?
Correct. So that same idea of developing a allergy, they're curious if the risk varies based on how many foods have been eliminated.
So can the risk vary? Yes, because we are eliminating one food versus many foods. So the risk is there. It all depends on the allergy potential in that particular child based on their immunogenicity and things like that. So the risk is slightly higher theoretically, but practically, have I seen any? I have not. Partly because I always work with an allergist before I make the decision, so that we can look at as more comprehensively with the patient, the family history, past history. We have to put them together and see what would work best for this patient. So certainly if the patient do need to go for something like elimination diet, when we introduce the foods, we will have another opportunity to see if that particular food that we're going to introduce is going to be safe or not. At that point, probably if the patient requires some testing, the allergist can work on doing some testing before deciding whether that is a safe food to be introduced or not. But the risk is generally low. Can it happen? Yes. So that's why, as I said, a multidisciplinary team approach is extremely helpful in making these decisions.
Thank you. You've talked a lot about how food elimination diets can help with EOE. Do you also use them for people dealing with lower EGIDs?
So I do that, especially in younger kids who have come in with the diarrhea or bleeding and things like that, and they are not the FPIES version, or if they have issues with sometimes patients can have milk protein intolerance, especially in the first 1 year of age. They can have sometimes vomiting, diarrhea, and bleeding, and things like that. In those patients, diarrhea appears to be the most common issue in the majority of the patients. So, do we do the diet elimination? Yes, we do start with that, especially in younger kids, which is much more easier for the patients to find the right foods for that particular child. So, we usually start with the diet elimination for those patients. Because the medical therapy is not as well studied in EGIDs compared to the EOE. So dietary therapy appears to have a much more significant impact or early impact compared to the medications. The dietary therapy has a better impact. So we always start with the dietary therapy. I always recommend to start with the dietary therapy, starting with one food at a time and then go up if possible and see what happens. Dietary therapy seem to have a greater impact compared to the medications, especially for example, in UAE, we have Dupixent, we have topical steroids, but for the gastritis or the duodenitis or the colitis, it's hard to know how much of the medicine can be delivered to those parts of the body, which makes it very difficult to say how quickly the patients can respond to it. And dupilumab is not approved for the kids with the gastritis or duodenitis or colitis. So lack of knowledge about medical therapy also directs us to pick dietary therapy for those patients and then conditions.
You just touched on this a little bit, but another question we received was about dupilumab, and is it only effective in the esophagus?
Yeah, so there are a lot of studies that are going on now. Appears like it has clearly the FDA is approved for, especially for pediatrics, is approved for kids with EOE, and a lot of studies are going on now looking at the efficacy of it in the rest of the GI tracts. So far, the studies are very promising, and I'm hopeful that it'll get approved for other inflammatory conditions as well. But as of now, it is only approved for eosinophilic esophagitis.
You've talked a lot about how to manage the condition. Some people are curious about what are the indicators that the conditions are going into remission. Is this something that people have the opportunity to outgrow, or is this something they're going to live with lifelong?
Yeah, so that's a very good question. But so this is also well studied in eosinophilic esophagitis compared to gastritis or colitis. In patients with gastritis or colitis, there are different forms that have been reported, such as like periodic flare-ups, and then coming back to baseline. You have the flare-ups, you treat them, and then they may go back down to normal. Or there are patients who may have flare-ups, and then they may never go back to the baseline, but they come to a new baseline and then stay there. But eosinophilic esophagitis is what the most studied. It's shown that the progression can happen over a period of time. So we don't know the timeline. The timeline can be different for each patient and person, depending on many factors, many number of exposures, how frequent the exposures have been, what are the genetics behind, and what their immunological status. So there are many factors that can influence about how quickly the disease can progress. But a lot of studies are indicating that this disease can continue to progress if left untreated. So the current recommendation is once it is diagnosed, better stay on the condition, better stay on the treatment for a period of time to see whether the disease can stay in remission for a long period of time.
Thank you. If somebody has accidental exposure to a trigger food, whether it's eosinophilic esophagitis or lower down in the EGIDs, how damaging is that?
So, very good question. The question is how much of that exposure is and how frequently that has been happening and how long it has been happening. So again, the larger the exposure and the longer the exposure has been, the probability of ongoing inflammation is higher. If we're talking about, for example, the patient is on dairy restriction as their choice, the first choice, or the dairy restriction that confirmed that induced remission. If the patient had, periodic exposures, I'm talking about not straight dairy, but something that they ate that has some dairy in it. There's a big difference, drinking a glass of milk versus eating something that may have dairy product. There's a big difference in the antigenicity in that particular patient. So the risk, if it is a short exposures, meaning that the exposures happened in the last day or 2, 3, 4 days or something like that. Once you identify the exposures and then remove them, the esophagus can quickly go back. Generally, that short duration of exposures do not lead to symptoms because this is like infrequent exposures and the small amount of exposures. But the patients who are eating and drinking, kids are kids. Sometimes, they sneak on food, they eat food, and you won't believe how many times the kids go into the pantry when parents are sleeping. So, so in those situations, unfortunately, the inflammation will continue to progress, sometimes without parents' knowledge. So those patients may continue to have symptoms. So it all depends on how frequently the exposures are. And of course, the longer the exposures are, if it is left untreated, it can progress to more damaging inflammatory state.
Well, thank you so much for your time with your presentation, as well as your time to answer the questions today. We really appreciate you helping to educate people about living with pediatric EGIDs.
Thank you, Jen, for having me for this. And this is a condition very close to me. And thanks, APFED, for this opportunity. Thank you.
Absolutely. We also want to make sure we take a moment to thank our education partners for their support for this webinar series, including AstraZeneca, GSK, Sanofi, Regeneron, and Takeda. Our next webinar will be about EGPA and neurological impacts. We will be opening up registration shortly at apfed.org/webinars. You can join us on February 10th to be able to learn about this aspect of eosinophilic diseases. We have many different opportunities to be able to continue learning about eosinophil-associated diseases. In addition to the webinar series, we also have a podcast, Real Talk Eosinophilic Diseases. We encourage you to subscribe and listen. In the latest episode, we talked with Dr. Fei Ling Kwong about Hope on the Horizon, which is one of APFED's grants. Dr. Kwong received 2 of these grants, and so we talked about the progress and what has been learned through her research. You can find the episode at apfed.org/podcast, as well as on Apple Podcasts, Spotify, Audible, and more. We also hope everyone joining us will save the date for our annual patient education conference. We are headed to Denver, Colorado this summer from July 9th through 12th. We will be posting more information at apfed.org/conference. Another way to be able to continue getting involved is to share your story. We ask you to go to apfed.org/share your story and to be able to share information about your experiences. It's incredible how much your experiences can be able to help others. Finally, we encourage you to continue the discussion started today in our online community on the Inspire Network. It's a great place to connect with patients and caregivers for support. You can check it out at apfed.org/connections. So thank you again to everyone that joined us today. We hope you enjoyed this episode of APFED's EOS Support webinar series. If you have a question that did not get answered today, please email mail@apfed.org. And I hope everyone has a great afternoon.